Good afternoon. Thank you for being here. This is really exciting to have another opportunity to have someone from outside of our little universe bubble here at Western come in and talk about amazing things and research and in clinical arenas. Today, it's a little bit of both. We have Nathan Sackett. He has a MD, MS, and an RN. So that's nursing degree. And he's trained as an addiction psychiatrist, focusing on the intersection between substance use and psychiatric disorders. He attended medical school and nursing school at University of California, San Francisco, graduate school at UC Berkeley, and completed his adult psychiatry residency and addiction psychiatry fellowship at the University of Washington. He's now a junior faculty at the UW in the Department of Psychiatry and Behavioral Sciences, where he splits his time between seeing patients and conducting research. Clinically, he works primarily outpatient, seeing a range of patients with primary psychiatric issues and substance use disorders. His research focuses on the use of psychedelics to treat substance use disorders, with a particular interest in how psychedelics can augment the psychotherapeutic process and facilitate behavioral change. And when he is not working, he is spending time with his family and playing in the ocean.
Why, hello there. Can you all hear me okay?
Yeah.
Fantastic. So yeah, my name is Nathan Sackett. I am an addiction psychiatrist at the University of Washington. I appreciate the opportunity to chat with you all today. My talk is about 35 minutes long, and then there'll be some time for questions, which I find most people have a lot of questions about this topic. So I hope that we can spawn a lively discussion. So the title of my talk is The Center for Novel Therapeutics in Addiction Psychiatry, Attempting to Research Psychedelics for Addiction, the Why, the What, and the How. So today we're going to talk about three things. The first thing, the why. Why am I standing up here talking to you about addiction and psychedelics? What led me to this work? The second thing is the what, which is the center that I'm working to develop at the University of Washington. And then the how is how you all can be helpful and engage in this work if you are interested. So those will be the three main things that we're going to talk about. So first, let's talk a little bit about addiction in the broadest sense of the term. So the current scope of the suffering related to addiction is really hard to articulate. I think in many ways we've become numb to the suffering around us, and we have tuned out the pain that it causes. So I think it's helpful to review some general numbers. So the CDC reported as of December 2022 that there was 106,000 overdose deaths due to methamphetamine and opiates in the last year, which is a 14% increase from the year prior. Numbers for alcohol use are similar. There's an estimated 99,000 deaths in the last year related to alcohol. Similarly, with tobacco, yearly estimates of tobacco deaths are about 480,000 per year. Taken together, we can say that addiction to opiates, stimulants, alcohol, and tobacco combined, the yearly mortality is about 685,000 per year, which is certainly an underestimation given these numbers are quite imprecise. In fact, it's thought that the rate of addiction and addiction-related deaths is so great in the US. It's one of the drivers that the US is ranked 34th in mortality, despite us being the #1 in spending. And as we all know, mortality related to substance use is a difficult proxy. There are so many downstream effects, and these numbers are often profoundly watered down, with cause of death reported as an accident or a car accident or respiratory failure, when in reality they were overdose. But if absolute numbers aren't motivating, perhaps relative numbers are. If we look at mortality from other causes, I think it highlights some interesting points. Cancer-related mortality in 2022 is estimated to be 609,000. Think about that for a minute. Rough estimates of yearly mortality of addiction, I just told you, was 685,000. There's a greater rate of mortality in the US related to substance use than all forms of cancer. Now think about the resources we harness to fight cancer. Think about the hospitals we've created, the inpatient units. Think about all of the expensive pharmacologic treatments, radiation, surgical interventions, the research, the genetic testing, and all the new models of care. And now think about all the ways we've harnessed those resources to prevent cancer, all the preventative visits, colonoscopies, pap smears, prostate exams. Imagine if we utilize the same degree of vigilance to prevent and treat addiction as we did for cancer. Okay, on to psychedelics. So over the past few years, there's been a growing body of research that has demonstrated that psychedelics, when paired with therapy, may catalyze change in behavior and provide an amazing therapeutic opportunity to treat a range of psychiatric conditions, including substance use disorders. There's a growing number of small studies that have explored the use of psilocybin, of ketamine, of MDMA, and iboga, and others for a range of these disorders. And here are just a couple examples. Krebs and colleagues in 2012 did a meta-analysis of a bunch of studies done in the 60s looking at LSD for alcohol use disorder. In this meta-analysis, they found that for patients who received a single dose of LSD with psychotherapy, their rate of abstinence at 30 days was double that of placebo. A recent study by Bogenschultz at NYU done in 2022 reported that among a sample of 95 adults with severe alcohol use disorder who were drinking fairly heavily, they had a severe case of alcohol use disorder. If they received 2 doses of psilocybin and 12 sessions of cognitive behavioral therapy, their heavy drinking days were reduced by 41%. Matt Johnson at Johns Hopkins did a small pilot study in 2015 where he took a group of tobacco users, of smokers, and he gave them 2 doses of psilocybin with CBT. And at 12 months, 80% of those patients were abstinent from tobacco. At 30 months, 67% remain abstinent of tobacco. Those are astounding numbers in my line of work that I generally don't see. Now, this is not a new realization. Clinicians and researchers have long been interested in the use of psychedelics to treat a variety of pathologies since the 1940s. And then in the 1950s, researchers wondered whether LSD perhaps induced a state similar to delirium tremens. And they wondered if you gave LSD to someone, you induced this profound altering state, perhaps it would lead to some behavior change. And it seemed as though it did. But due to the complex political landscape that followed in the 60s and 70s, these treatments have been driven essentially to the fringes. And particularly in 1970, with the passing of the Controlled Substance Act, these treatments had to be driven underground and were done illegally for a number of years, without the ability to engage in research and learn from each other's experiences. However, the tide is shifting. Over the past 15 years, a growing number of promising studies indicate that psychedelic-assisted psychotherapy may provide relief and support and changes in behavior that we rarely see with other treatments that target addiction. Okay, so what's my story? How did I end up standing in front of you today? So as a resident physician completing my adult psychiatry training, I grew frustrated with the ways in which we were engaging with patients struggling with a variety of psychiatric conditions, including substance use disorders. I saw patient after patient presenting to emergency rooms and inpatient units and outpatient clinics, who were struggling with the complexities of addiction and substance use, and there was only a small handful of treatments available. I became increasingly frustrated with the way addiction was seen and the way we were expected to engage with it as providers. Over the course of my medical education and training, I began to understand addiction as a complex behavioral syndrome that can evolve from several different starting places, but that eventually seem to coalesce in this shared common pathway that lands someone in the emergency room or in a clinic where they are met with a limited number of treatment options. And by the time they're on the pathway to seek care, the power of many of our interventions are almost entirely lost. And they're overwhelmed when faced with the years of pain and suffering due to someone's substance use disorder. This mismatch between our available treatments and the accumulation of years of suffering often seems to feed into this felt sense of hopelessness, both by patients and providers. The path to the shared common pathway are diverse, but for most, eventually lead to a state of profound suffering. For an unfortunate some, one pathway seems intrinsically biologic, as if the alcohol or the opiates are the key that fit into their lock. For others, substance use is a seemingly rational choice, a means of urgently sought after pleasure or temporary relief of suffering brought on by trauma or boredom or curiosity. And for most, the syndrome is characterized by some mixture of the two, some mixture of circumstances and biology that seem to interact bidirectionally, and it results in a complex and poorly understood behavioral syndrome that we call addiction. As my understanding of addiction increased, so did my frustration with our treatments. And I recall the growing sense of cynicism and frustration with my sertraline, gabapentin, naltrexone, Librium, buprenorphine scripts, and feeling like there had to be a better way. Around this time, I began to hear stories from patients of mine about having transformative experience with psychedelics. I met with a number of patients at the VA who were using MDMA to treat their PTSD. I began to encounter patients with profound depression using psilocybin and had more results in 6 hours with psilocybin than perhaps years of psychotherapy. And so I did what every good trainee does. I scoured the literature and I devoured everything I could possibly find about psychedelics. I met with a range of practitioners and providers all around the country who were using psychedelics in a therapeutic context. I traveled to labs around the country and talked to researchers. I met with patients and interviewed as many people as I could who had any experience with psychedelics. And I met with as many people who would talk to me as I possibly could handle, day after day after day. Throughout this exploratory phase, I grew to wonder if psychedelic-assisted psychotherapy may provide a powerful tool that can address the many complications associated with addiction. I began to understand in these conversations that perhaps psychedelics may act to catalyze engagement and inspire behavioral change in powerful ways. While clearly having some biologic effect, it also allowed people to see their life through a different lens. And that to me was a really powerful realization. It was this appreciation that psychedelics can be an accelerant to the therapeutic process that really struck me. Finally, I thought, a treatment that can meet the needs of my patients. So armed with this excitement, I tried to find anyone in my department or the university doing work with psychedelics, for which there were none. So I started the psychedelic interest group among my peers. It was a way for me to engage with my colleagues while still not totally outing myself as a complete freak. We would meet in random basements, in classrooms on campus and review papers. We would discuss pharmacology and the history of psychedelic use. I then joined the behavioral pharmacology lab of my mentor, Dr. John Neumeier. Dr. Neumeier was working with Schedule I compound, MDMA, with mice. And I thought, well, if I can't work with humans, I can at least learn some of the methods used in animals. And the more I learned, the more convinced I became that the University of Washington needed to participate in research to explore psychedelics for the treatment of addiction. Now, fast forward a few years. I completed my adult psychiatry training. I finished my work with Dr. Neumeier in his lab. I completed my addiction psychiatry fellowship, and I joined the faculty at the University of Washington. And I began working as a psychedelic psychotherapist on the first clinical trial at the University of Washington, where we gave psilocybin to frontline providers of COVID, so nurses and doctors, and to see if it could help some of their burnout and essentially trauma-related syndrome. And in April of 2022, we put on our first meeting and officially launched the center, or my lab, the Center for Novel Therapeutics in Addiction Psychiatry, where we had about 130 people come and help us brainstorm about how we should prioritize our time and energy in making some of these projects a reality. Now, I realize that many of you may think I'm crazy, and I very well could be. Since joining the faculty and telling folks that I was aiming to develop a research center at the university, exploring psychedelics and addiction, I have heard countless reasons why this would fail. I was told it was politically dangerous, that it would backfire. It was too controversial. I was told I was too junior, that I wasn't a real researcher, and that I would never get institutional support to make this happen. Trust me, for every one of the reasons that you can come up with why this will fail, I can give you 5 more. But I also believe we're at a critical crossroads. Psychedelic-assisted psychotherapy is here to stay, whether we study it or not. The fact is, there's a major discrepancy between the current demands for these treatments and our understanding of how they work, driven by people's desperation. And we need more treatments, and we need them now. And personally, I'm not patient enough to stand at the sidelines and wait. And so with that in mind, I decided I'd throw all of my weight in trying to make this a reality, to set up a center where we could pursue this work. So now let me tell you a little bit about the center. So the Center for Novel Therapeutics and Addiction Psychiatry functionally aims to bring together experts from different fields who are interested in better targeting treatments for addiction. Essentially, I want to mix people with experience in the basic sciences, in the clinical sciences, in medical education, in public health, so we can all share our understanding and our motivation to try to move things forward. The primary questions that I'm trying to address in creating the center is, what psychedelic or novel compound is best paired with what behavioral intervention, and how could we use that pairing for the appropriate patient population? To answer these 3 clinical questions, the center is composed of 3 central pillars: an education and training pillar, a preclinical pillar, and a clinical trials pillar. Each pillar acts to inform the other, so we can create a translational organization where we can gather epidemiologic data, we can run early experiments using animal models, we can then develop clinical trials and create evidence-based trainings and guidelines and teachings across the large educational landscape at the University of Washington and regionally. Now, this idea is not a new one. There are many institutions who have already developed centers focusing on psychedelics: Johns Hopkins, NYU, UCSF, the list goes on and on and on. But this center is unique in 3 specific ways. First, this center is not just a psychedelic center. We are mission-driven, and our primary focus is to find treatments that work. We're focusing on psychedelic-assisted psychotherapy right now because I believe that there is strong evidence that this could be truly helpful. My main goal, and I say this to everyone who will listen, is that I'm a psychedelic agnostic. I'll pursue whatever line I can, whatever works for my patients, that's the route that I'm going to take. Second, the center is fundamentally focused on the interplay between the pharmacologic interventions, aka psychedelics and other compounds, with the behavioral interventions like cognitive behavioral therapy and group therapy. The center aims to bring together a range of experts from a diverse set of backgrounds who have training and expertise in dialectic behavioral therapy, in internal family systems, in a variety of different behavioral models, with experts in pharmacology, so we can maximize the 2 together. And lastly, the center is unique in that one of our primary aims is to engage meaningfully with the community. We're not just living in a lab or in some research center off in the university. We're really focusing on finding clinically meaningful treatments that are safe and effective that we can actually get into the patient's hands. And we can't do this if we're isolated in some lab somewhere. Okay, now I'd like to explain a little bit about each of the individual pillars so you have a better sense of the concrete elements of this work and what it looks like. Excuse me. Okay, for the educational pillar. So the education and training arm of the center is bringing together educational experts in addiction, in harm reduction, in pharmacology, to try to better understand how we can train providers to use psychedelics and other novel compounds to treat addiction. To that end, we've given a variety of educational lectures, both regionally across the state and nationally. The center has given talks to all sorts of audiences of diverse backgrounds to try to inspire further conversation about this potential work. Additionally, we're currently developing an educational program called an Echo Clinic. And an Echo Clinic is a train the trainers model where essentially providers in the community emergency room docs, family practice docs, social workers, therapists, psychiatrists come together each month. And there's a curriculum that they follow where they learn about psychedelics. And then there's a case series where they can discuss cases as a group. The idea here being that we need to increase providers' comfort with talking about psychedelics, increase people's psychedelic fluency, if you will. And that's what the goal of this Echo Clinic is. Eventually, I hope the center can be instrumental in developing a range of educational opportunities for people and people interested in psychedelic neuroscience, psychedelic psychotherapy, psychedelic pharmacology. But that's obviously a longer, loftier goal that's going to take some time. The preclinical arm is really focusing on bringing together experts from the basic sciences and how can we tap into this large network of basic science work going on throughout the university and share those resources to move ideas from the bench into a clinical trial. One of the projects that we're recently engaged in is we have partnered with a lab at the University of Washington called the NAPE lab. I think it's the Neuroscience of Addiction and Pain by Dr. Charlie Chafkin. His team developed an assay in mice where they gave very low dose of a drug called a kappa antagonist. The kappa receptor is part of the opiate system. And they found that you could give very, very small doses of a kappa antagonist and still see downstream physiologic effects. And the hope is that this may play some potential role for relapse prevention drugs in the future. Once his lab created this assay, they now came to me in the center to say, could we develop a phase 1 clinical trial in human volunteers to see if there's any feasibility in the kind of biologic mechanism of this? And so we're working on that right now. Additionally, the center has developed relationships with a range of different biotech companies and universities where we're trying to figure out a way where when learners and trainees and faculty have ideas that they want to pursue around the treatment of addiction, that they can come to the center and we can help pair them with appropriate mentors and appropriate logistics. Over the long term, the center seeks to work with labs in neuroscience, pharmacology, anesthesia, psychiatry, and psychology to really help us better understand the safety and the possible biologic and behavioral mechanisms of these various compounds, which can then be used to inform the third arm of the center, the clinical trials arm. So the clinical trials arm seeks to provide infrastructure and support for human clinical trials, from early phase 1 healthy volunteer trials to phase 2 interventional trials and phase 3 multi-site trials. The center is currently working on a healthy volunteer study to inform dosing of ketamine to treat tobacco use disorder. We're actively developing the assays needed to develop and implement different models of psychedelic-assisted psychotherapy. We're working to develop different outcome measures. We're exploring issues of dosing, and we're trying to find different mechanisms to best study the pairing between the behavioral intervention and the psychopharmacology. We then plan to use this developed infrastructure to pivot into other clinical trials. And we recently created a partnership with the University of California at San Francisco and the University of California at Berkeley and applied for some funding to do a multi-site trial looking at psilocybin plus cognitive behavioral therapy for alcohol use disorder. Additionally, the center is currently working in collaboration with colleagues over at Washington State University, where we're conducting a qualitative study of underground providers who are engaged in psychedelic work. We are interviewing a range of providers to try to capture what exactly people are using and what they're seeing. These treatments have been driven to the fringes and people have been afraid to talk to each other and to share stories. And to me, this seems like a missed opportunity. We have all this naturalistic data of all of these providers seeing patients after patients after patients. Is there a way we can pull from some of that and learn something that'll help inform the trainings in the future and potential other clinical trials? Over the long term, we hope the center is instrumental at developing multiple clinical trials where we can expand from small observational studies and small pilot studies, and we can really use this to push treatments in a more rapid and robust way. I envision a day where we have trials exploring the use of psilocybin and 12-step facilitation for alcohol use disorder, or ibogaine and motivational enhancement therapy for opiate use disorder, or ayahuasca and motivational interviewing for tobacco use disorder. I envision a day where patients who present to our acute care hospital can get enrolled into an appropriate clinical trial in real time over the vast network. The catchment area of the University of Washington is 5 states. So we have this huge catchment area with all these patients who are desperate for care. And my hope is that the center can funnel people into these trials as a means to better understand their efficacy, but also to see if we can get them the treatments in the short term. As we grow and develop more clinical trials, we'll be able to use these findings to feed back into our training and education arm and into the preclinical work to inform future clinical studies. There is a range of questions that have already emerged that we're trying to figure out how to explore, like can we figure out ways to make psychedelic-assisted psychotherapy more scalable and more equitable? Can we administer it in groups? Can you administer short-acting compounds that say, you can give someone DMT that may last 15 minutes. Does that have a similar effect as psilocybin, which may last 6 to 8 hours? Does the intensity of the subjective experience matter? To what extent does the set and setting matter? There's so many questions that we need to try to answer. But as you can probably appreciate, we've got a lot of work ahead, which brings us to the last step of how you all can help. So the center was officially launched in April, and at that point, we hosted our first meeting, like I said, where we had 130 people throughout the community interested in this work. Since then, we've made huge strides, and we've evolved from a harebrained idea from a large resident like me into an actual center. And it's evolved now where we have 25 UW faculty who are involved from 4 different clinical departments. We have a scientific advisory committee, a community advisory committee, and we have over 300 interested volunteers who are helping out on a range of projects. But with high-risk projects comes challenges. We're faced with 2 primary challenges, hence the title of this talk, Attempting to Research Psychedelics. First, we need more human capital. We need people like you who are interested in this work and want to engage. We need to further develop educational curricula. We need to figure out how to target different audiences, from everything from undergrad to postdoc. We need to develop collaborative relationships with other labs who are doing a range of experiments in isolation, and we need to try to share those experiences across different institutions. We need folks who are willing to write grants. We need people who are willing to help mentor. As you can see, there's a lot of work that needs to get done. And then, of course, the other big problem is funding. Because these compounds are illegal, we don't have any federal funds. It's all essentially philanthropy. Now, the university has been supportive in that they've provided some initial seed funding, but I spent a lot of my time fundraising, trying to gain more funds so I can get more projects going. And as you can imagine, each of these clinical trials are tremendously expensive. It's estimated that for every psilocybin trial, it's at least $1 million per trial, just to give some sense of the scale. And it turns out it's hard to go up to random strangers and get $1 million check. However, despite these challenges, I look around at the University of Washington and this region, and I see an institution with national and international experts in medical education, in addiction, in basic neuroscience, in clinical and research psychology, in psychiatry, palliative care, pharmacology. I see an institution with vast expertise and technical skills, utilizing the most advanced research techniques from health service research to advanced neuroimaging. I see a university with collaborative opportunities with multiple other institutions in the region, like y'all, OHSU, WSU, UCSF, and a number of other universities throughout the area. I also see a university that is based in a city where we've decriminalized psychedelics, where our neighbors to the south in Oregon have recently passed Prop 109 and 110, allowing for the use of psilocybin, and it seems just a matter of time before Washington follows. We live in a region that has a rich history and a huge network of providers using psychedelics therapeutically, and they have for decades. And we live in a time where there's growing evidence that things like MDMA and psilocybin could be rescheduled as we gain more evidence and could be a real game changer in psychiatry and in mental health. We also live in a time where we can no longer escape the human suffering caused by addiction. Walk in any neighborhood at any time of day and you see the evidence of that. From the needles in the park to those friends and family members who are increasingly struggling with alcohol to numb the sadness or the boredom from the pandemic. A few years ago, I used to meet with faculty and colleagues and try to convince them why we should engage in this work. I'd cite the most recent data, I'd give them talks, I'd give lectures, I'd try to argue my case over and over. However, now I've come to understand the question very differently. Now I find myself asking, why wouldn't we engage in this work? Thank you so much.
All right, so we have by design a lot of things here in terms of time for conversation. Any questions? I know there's probably questions on a whole bunch of different levels, and we'll have people on Zoom and some questions from before. But I think we can get started. First, raise your hand and let Dr. Sack.
I saw you first, so you.
Do you see psychedelic psychotherapy being used in combination with established treatments like good agonist therapy or most of the whole thing?
That's a very good question. There are currently 2 trials going on right now looking at psilocybin in combination with buprenorphine and another one looking with methadone. I think that it is my personal opinion that psychedelic-assisted psychotherapy is going to be an augmenting agent for currently available treatments. Yeah, I think we need to be cautious about not throwing out too many available treatments right now. We need to work with what we can, and I hope that that psychedelics can potentially improve engagement in other forms of treatment. Yeah, that would be my hope. Does that answer your question? First. Yes.
So I guess I have a two-part question. First part, when you first started trying to do or giving providers psilocybin, were you doing it in one dose, like larger dose, or were you doing microdosing? And then are you more hopeful for a microdosing format of psilocybin or kind of one dose treatment?
Yeah, that's a great question. So there's a lot of kind of cultural interest in microdosing. It is my personal belief that one of the primary therapeutic mechanisms of psychedelics is the subjective experience of being in an altered state of consciousness. So for the clinical trial we did for healthcare workers, we gave them a macro dose. The thinking being that for a macro dose, you want to get people in a state where they can experience their own story from a different lens, from a different angle. And I think that microdose, while I think there could be potential for microdosing for some indications, my interest lies more in the macro dose. Does that answer the question?
Absolutely.
Yeah.
So I'm a master's student here and plan on applying to a couple of neuro PhD programs you have included. Is your center something that you would take in PhD students, even just as volunteers, to aid in research?
Yes, please.
What does that process look like?
We'll talk afterwards. I'll give you my card. Yes. Yeah. Oh, sorry, I'm not repeating them. Sorry. Yes. I will repeat the question. Yes. Yeah.
So when you mentioned DMT, you mentioned it in like very brief exposures. So I wanted to know what you thought about the trials now that are coming out, where they're giving people DMT intravenously and they're able to produce extended periods of exposure to the drug.
Yeah. So the question.
Define that. Just some of these drugs that are
Yeah.
sort of playing with a lot of people.
So the question was around DMT, which is a serotonergic psychedelic. DMT is pharmacologically very, very short acting. It generally lasts about 15 minutes. There is a group that is now doing what's called targeted controlled infusion, which is essentially a method of giving DMT in a continuous way so people can sustain this kind of altered state. I think it's this notion of giving people DMT in a longer acting form, I think is interesting, kind of from a scientific experience. I don't know how practical it is when, why would I hook someone up to an IV and titrate DMT over a number of hours when I could give you psilocybin, and for 6 hours you will be not tethered to anything and you can have a similar experience, right? I mean, DMT and psilocybin are phenomenologically slightly different, but I think it's interesting, I guess, is my answer to your question. I don't know its therapeutic value yet, but I'm hopeful that maybe they will apply it in a therapeutic way. Yeah.
Incorporating indigenous cultures that have involved with using psychoactive substances.
Yeah, so the question is really, is there any work being done on integrating perhaps indigenous cultures who have used psychoactive active substances in a variety of ways? Yeah, that's a complicated question. I think it is, so from a research perspective, it is difficult to engage in a lot of the indigenous communities. There's obviously suspicion of researchers, and so it has been a challenge to engage. I think there's a number of people who have tried to reach out to different groups who have a lot of experience with psychedelics and engage with them in a meaningful way. It's still something that I'm trying to figure out how to do in a thoughtful way. In the same way that I'm doing this qualitative study to interview underground providers, I would love to do a qualitative study talking to different groups who have a lot of experience historically using these compounds. So if you have any ideas of how I can do that, give me an email. Yeah, for sure. In the very back, yeah. Yeah. So the question is to what extent do I think psychedelics interact with harm reduction theory? I mean, to me, they seem, I don't see any kind of conflict with that. I think, just to be clear, when we talk about harm reduction is really, in my opinion, focused on what can we do to ensure that we're meeting patients where they're at. We're not coming at them with this like pejorative finger wave, just say no to drugs, right? Like we know people are going to use drugs. What can I do as a provider if you're going to use substances, what can I do to help you be safer, right? I very much utilize that mentality with psychedelics right now. I mean, we don't have a lot of good evidence to show how to best use these compounds, and yet I know that a large portion of my patients are using psychedelics in all sorts of different ways. So part of my job is using harm reduction to talk to them about, do I love that you're going out and using MDMA from an unknown source in an unknown environment? No, I don't think that's great. But what can we do to try to make it as safe as possible? So from a clinical perspective, I think harm reduction is something that I utilize often. In terms of its approach, I don't see there being any conflict there. I think that we can utilize psychedelic psychotherapy to help people meet whatever goal they have, whether that be abstinence or reduction in use or use in a more safe way, or however. I'm open to that. Gentleman with the hat.
Oh. So I feel like we hear a lot about like mushrooms and MDMA and ketamine therapy now for being researched, but I'm curious if LSD has made its way back into being researched yet. I know like the founder of Alcoholics Anonymous, I'm pretty sure like kind of creating that to LSD. And
yep, sure did.
I also feel like with the decriminalization, LSD is never in any of the decriminalization bills. So I'm curious like what your thoughts are on that.
Yeah, I think there's a complex history with LSD. I think one of the difficulties with LSD is, quite honestly, it's a PR thing. Like, I think there's still a lot of remnants of people who have this idea that, it causes chromosomal damage. Everyone has that story of like, so-and-so did X number of hits and then they went crazy, and that narrative is still very much alive in people's minds. And what I often remind people is that people who are experimenting with LSD are often of the age group when psychotic illnesses also present. So if you're 20 and you're dropping a bunch of LSD and you become psychotic, did the LSD cause the psychosis? Probably not. What probably was happening was you were having a psychotic process that was evolving, and the psychedelics, LSD in specifically, perhaps tipped you over the edge. The point is, though, that LSD, I think, still carries some difficult stigma to overcome. Yeah, you read, that's exactly what I say. The length is just, I think, clinically a little bit more difficult to work with because it lasts like 9 hours. And, from a health delivery perspective, that causes some logistical challenges. That being said, there are groups that are doing studies with LSD. I mean, there's a number of groups throughout the country that are exploring different analogs of LSD and LSD directly. So I suspect that we will see more clinical trials in the future. I'm particularly interested in using LSD for alcohol use disorder, given, like you said, Bill Wilson, the founder of LSD, or the founder of Alcoholics Anonymous, did LSD and had this spiritual experience that is largely accredited or thought that it was part of the formative elements of AA and the kind of spiritual component. So there's a lot of history there. Yes.
We have a question from our Zoom audience. It says, a lot of medical health officers will focus on total abstinence. Is there a pushback from patients with a perceived breaking of that abstinence to utilize these treatments?
So I think what the question is getting to is, yeah, there is in some treatment philosophy that it's abstinence only. Yes, there is some pushback against that. And the reason that there's some pushback against that is we need to think and separate out, when we think about addiction, we have been all told all of our life that, if you go and, take an opiate or take methamphetamine, the next stop for you is like, junkie, right? Like we are told, we demonize the substance and we are told that they are awful. And, which may be true for some of you, but I think the reality is for most of us, it's an accumulative process that is a function both of you as an individual and the substance itself. Cocaine or crack or methamphetamine are highly dopaminergic, right? They hijack the dopamine system in your brain in a very profound way that put you at greater risk to developing a problem with it. Whereas psilocybin or ayahuasca, where you're puking your brains out, is not very reinforcing, let me tell you. It is not a pleasant experience. So this notion of you using a psychedelic compound for therapeutic intent, I think is better tolerated because you don't really see very many people going out and, using LSD day after day. Another reason that it's somewhat tolerated, I would say, among some recovery circles is that with the serotonergic psychedelics, there is this experience, this phenomena called tachyphylaxis, which is essentially once you do LSD, the receptors, the 5-HT2A receptors, downregulate. If you take it again the next day, nothing will happen. So there's sort of this anti-impulsive cycle that is intrinsic to the medication, which I think lends itself a little bit more to using it with substance users because they are less likely to kind of binge on it. Now, that being said, I always say this, anything can be overused. And I have seen people who have use disorders that pertain to psychedelics. So I don't want to say, oh, psychedelics are totally safe. They need to be used, I think, in a therapeutic environment that is very thoughtful. And there has to be some guardrails around that. I certainly wouldn't advocate for any of my patients in my addiction clinic to go out and just go take LSD, right? It's more complicated than that. Yeah.
Development of serotonergic psychedelic molecules that don't induce hallucination, and I'm curious if you think there's therapeutic application there, maybe not, it might not induce such an intense subjective experience of using.
Yeah. Yeah. So a lot of this work. So the question is, there has been development largely by Dr. Olson at the University of California at Davis, who has pushed this idea that perhaps the subjective experience is just an adverse event and you actually don't need it. And perhaps you can develop serotonergic agents that induce synaptic plasticity without having the experience of being, gorked out on a psychedelic. Do I think there is application there? Yeah, sure. I mean, pharmacologically, it makes sense that there might be some benefit for some people. It's my personal opinion that the therapeutic benefit of psychedelics comes from the subjective experience. And I think a lot of evidence shows, especially for substance users, that when people have a more intense experience the more intense experience they have under the influence, the greater the likelihood is that they will abstain or reduce their use. So to me, I think mechanistically, I think the subjective experience matters, at least as it relates to substance users. But I think, Dr. Olson's work is powerful and important, and I think we need to pursue that as well. I mean, I will pursue anything that I think helps, and if it works, great. Yes.
Maybe psilocybin trial is around $100.
Mhm.
Explain what a $100 trial is.
Yeah, so the big costs is the sheer administrative burden to get the trial set up. The amount of regulatory barriers to get a trial approved. You need to go to the FDA, you need to get approval from them, you have to go to the DEA, you have to have a special safe, you have to have a whole protocol developed on where the med is going to be stored, what you're going to do with the extra. The infrastructure costs are so great that the barrier to entry is quite high. So that's one big cost. The second big cost is labor, because the standard of clinical trials that have been done right now involve 2 therapists sitting with a patient for the duration of their trip, which in itself, I mean, you have 2, oftentimes docs or psychologists or nurses sitting for 8 hours at a time with each patient. I mean, that's tremendously expensive, right? So those I think are the major drivers of those costs. Yeah, does that address your question?
All those doctors are there. Them and trying to get thoughts.
Yeah, I mean, it depends. It depends on the. Yeah, so I would say, and again, this is just my opinion, this notion of having 2 highly trained therapists in the room, I think is a little bit of an overkill. Because quite honestly, when someone is on psilocybin, you're not doing a lot of psychotherapy in the room with them. You're trying to make sure that they're not going to jump out the window or hurt themselves. You're trying to make sure they feel safe. You're maybe holding their hand while they're crying, but you're not doing a lot of deep, intensive psychotherapy work. That really occurs afterwards. So it's become the standard. And so because to get a trial going, you have to follow kind of the footprint of the prior trials. And so it's become kind of normative, but I hope that changes soon because I think it's a little bit overkill. Lots of hands. Yes.
I have a question from Zoom that I think follows well with that. But it was about the process of treatment, what it looks like. Is it ongoing or is it more single and frequent?
That's a great question. So we don't have a lot of good data on what's called the durability of treatment. So just to be clear, in case people don't know what this treatment looks like. So if you were to come to a clinical trial because you have profound depression, what you would do is you would see the therapist or the 2 therapists, you'd have a couple sessions with them. Then you would have a session where you receive psilocybin and you sit with them for 6-8 hours, and then you have follow-up therapy thereafter. And that would kind of be considered an episode of care. Most clinical trials do that 2 to 3 times over a month or 3. Beyond that, we don't have good data on the long effects of that. We don't really know. And again, part of that is a function of funding. It's really expensive to track patients long-term. And so given the high cost to engage in these trials, we don't have a lot of long-term data that follows after that. So we just don't know. Yes, you in the back.
The mindset of being in a clinical environment as opposed to a more natural or more free or open environment, and is there any direction for opening that up, or right now are you reverted to medical?
Yeah. So the question is set and setting, and is there any push to get clinical trial work done in a more naturalistic environment, in a natural environment as opposed to like a hospital room? Yeah, I mean, certainly just from my perspective, I would never, ever want to do psilocybin in a hospital room. To me, that would be like kind of hell, you know? So I would love to get a clinical trial where we could take people out in the woods and like hang out with the trees. To me, that would probably be far more therapeutic. The challenge with that is obvious, just all the regulation and the regulatory concerns and safety. And at this stage of where we are in the research arc, it's gonna probably be a little while before we can get to that spot. But I certainly hope that in my lifetime that could be something that can be done, because I agree that, like, I mean, I think you're implying that you wouldn't want to do that either. I don't know anyone who would. Yeah.
How much do you think the benefits of psychedelic depend on the person?
How much I think I mean, I think like all treatments, there's a tremendous amount of variation. The psychedelics themselves are perhaps helpful. They can catalyze some things, but it's really, I think there's a lot of moving parts in that equation. So yeah, it certainly depends on who you are as a person. And there are certain traits that have been shown to be better paired with certain psychedelics. And so obviously the data is still relatively young, but that's something that we're trying to better figure out too and characterize, like, is this super neurotic person a good candidate for psilocybin versus someone who's more profoundly depressed, and how do you differentiate those things? So the short answer is yes, it's a huge variation.
Right. The reason I asked that is because you said cognitive behavioral therapy shows like it takes a time. It's over the course of a long period of psychedelics show results in 6 hours.
Mm-hmm. So
that, like, thinking about a world where we live in where psychedelics always take cognitive behavioral therapy because of how short term it is, but I guess it's really dependent on the person. Right?
It is, and I think they're targeting two different things. I mean, I think the way that I look at it is for anyone, whatever form of therapy you want, call it whatever acronym you want, the therapeutic work is going to result, I suspect, in long-standing change. That's the durability of treatment I was speaking about earlier. That's where you're going to probably see that change, but that is slow. And it is hard to get people to motivate to engage in that. And I see the psychedelic as the potential motivator to help people engage in that. So to me, they're kind of targeting two different things. One is about engagement, and the other one is about kind of long-term behavioral change. Yeah.
How realistic and effective do you think it is to get somebody who's experiencing active physical dependence that is, for instance, withdrawal or a psychedelic without mitigating that experience?
I mean, that would be a terrible idea. I would not, if anyone was having acute withdrawal from any substance, I certainly would not suggest they get a active psychedelic. I mean, just from a medical perspective, if someone's actively withdrawing from opiates or alcohol in particular, that needs to be treated. And that would not be the time that I would want to engage with someone with psychedelics. I would want to wait until they are at least in a stable physiologic state before engaging with them.
You think that psychedelics would be better used for people that are not in active addiction, but they can be like past that first step where they don't have that kind of thing?
Not necessarily. I think that for some people, people can have a dependency, let's say, and they are ambivalent about whether they want to stop or not. And the psychedelic experience could be a helpful tool for them to help solidify their motivation and help them decide what they want. So I think that's a potential benefit, or then afterwards. But I would certainly avoid the active withdrawal phase. I think that would be unwise. Yeah.
So in terms of treating different disorders in which psychedelics you choose to use, like you mentioned, a lot of psilocybin treatment for alcohol use disorders. Is it the phenomenology of the particular drug that you're seeking out when you give someone a particular compound, or is it the profound experience of psychedelic drugs, period?
Very good question. To be determined, my friend. I have no idea. I think, I mean, it's unknown. That's a very, very hard question to address. I think there are, some suggestions that some psychedelics are better paired with certain disorders for certain physiologic reasons. But I think we are a long ways out before we can better match those two things. So I don't know. Yeah.
You mentioned major depressive disorders, something you guys are looking at for treatment. And I was curious on, I don't know if they were saying, is it better to treat it or give them psilocybin when they're having an active episode, or would it be better to do it when it's not?
So I think the difference that I would say between someone who's actively using or someone who's actively depressed, I would say, to your question, someone who's profoundly depressed, it would be, in my opinion, and the evidence I think suggests this, that it would be an okay time to give someone a psychedelic. For people oftentimes who are profoundly depressed, they lack motivation to like engage in treatment, engage with their therapist, engage with their family. And so I think for some people, and again, we don't quite know who, the psychedelic could be a catalyst that can push them to like go see their therapist, go see their family, go see their friend, engage with their, So I think actually in that setting for depression, it's a little bit different and it could be useful.
Another question from on Zoom. It was regarding using psychedelics and researching that for other addictions like gambling.
Yeah. To my knowledge, there are no clinical trials that are looking at behavioral addictions in psychedelics right now, although I can imagine there will be a time where we will explore that at some point. I think behavioral addictions are a little bit more challenging. I mean, it's hard. Yeah, I think that is a lower priority, mainly because gambling addiction is not killing 100,000 people per year right now, whereas opiate use disorder is. So I think there's a different degree of urgency. Not that people with gambling disorders don't deserve care, because they certainly do. But in terms of when I list the priorities, I need to think about it kind of from a public health perspective. And so gambling use disorder or gambling is kind of on the lower end of my priority list at this stage. Yeah.
$1 million for a trial is expensive.
Yeah.
Unless you're a pharma company.
Yeah.
So how is your center engaging pharma? I understand they probably don't want to run a trial on necessarily psilocybin.
Yeah.
But I'm sure they have libraries of compounds that are similar.
They do.
Could easily.
Yeah.
throw some money.
Yeah. So the way I'm engaging with pharma companies at this stage is to develop relationships where we can do phase 1 healthy volunteer trials, essentially, kind of early investigatory work where we can help characterize the subjective experience of these compounds. It comes at a cost, right? Like, I'm very cognizant of the fact that, like, I'm very suspect of pharma companies. And then here I am taking potential contracts for these other biotech companies or pharma companies. And, I have mixed feelings about that. And I want to see the work get done. So unless y'all know some multimillionaire who wants to give me a large check, like, I feel a little bit stuck, I don't love it.
How much, if you move the needle with them, how much of that can you then say, hey, look, this works, we can use some natural therapies? Does that feedback? Yes.
I mean, the hope that I have, and maybe this is naive, is that I could exploit the financial gain from these pharma companies to develop infrastructure where I could then develop trials that I'm interested in, which are going to be less effective or less financially profitable for people. I'm really interested in, like, group therapy and psychedelics. Like, who's going to fund a group therapy? Like, there's no money in that. That's the way that I'm morally justifying it.
So obviously you can't do like a preclinical trial using like CBT and stuff like that, because you can't really use psychoanalysis on a mouse or something like that. But does your center, or will your center, also be kind of looking into preclinical trials, especially if you're working with these biotech companies that are giving similar compounds, just to kind of get more mechanistic justification?
Yes. So the question was, am I collaborating with labs doing preclinical work? Yes, absolutely. I'm collaborating with a number of different labs doing kind of early investigatory work around mechanisms, different neuroscience labs trying to kind of characterize the binding profiles, the pharmacokinetics, and so forth. So yeah, I'm definitely doing that. Yes, you in the back.
So I can't remember the scientist's name, but I know around 3 or 5 years ago, there was someone that was mass creating their own chemicals, like their own psychedelics in their home. And he was testing the cells, finding like very, very drastic effects, bringing in some stuff similar to psilocybin, I think so. But regardless, it was over 500 substances that created that this psychedelic properties. I'm curious if there's any research on some of that stuff.
There certainly is, yes. So you mentioned Shulgin. So Shulgin is a kind of a mad scientist, pharmacologist in Berkeley who him and his wife had a lab, and they just, I think he was a synthetic chemist. I don't actually remember his training, but he pumped out a ton of psychedelic compounds that they tested on themselves, wrote a book about. I know a number of biotech companies that have essentially taken his notes and recreated those and are running with them. So yeah, certainly that is being done. Yeah.
Do you expect a pretty non-trivial number of people who are suffering from addiction, schizophrenia, and other psychotic disorders to be able to benefit from psychedelic therapy? Or is that going to be pretty situational compatibility there?
It's hard to, at this stage in the game, an exclusion criteria is people with psychotic illness. And that's probably not well-founded in terms of evidence, but that's become kind of the cultural norm. So I don't know. To answer your question, I'm not sure how that's going to play out. Yeah, to be determined. Yeah. Sorry. Nothing that I can speak of yet, no. Yeah, I will say this, the experience has been quite profound.
Okay, I'm not gonna kick you all out of here, but I just want to be mindful of the time in our Zoom session will run out. And Dr. Sackett will be here for a little bit longer, and we can have some interaction up here. How many more business cards do you have?
I have a couple more.
So for now, we'll just say thank you so much for.
Of course, thanks for having me.